Happy New Year, everybody. Welcome to January's Transformation Talk. Today we'll be talking about health equity, and I'm excited to have everybody be able to see this presentation. My name is Maria Corrigan, and I'm the Special Assistant for Systems Transformation here at the Department of Health. We hold these transformation talks every month, and I'm hoping that folks out there are regularly able to join us. Isn't really called out specifically, but I think we all know that health equity is one of our really our primary guiding principle, really wanting everybody to achieve better health. And in our role as Chief Health Strategist, not only are we trying to achieve this ourselves as we do our public health work, but we are providing leadership for other partners. It is a great thing to hear a lot of people talking about health equity these days. Many of our partners are talking about it, and I think we have a strong leadership role that we can play around guiding people in terms of how to look at health equity and the things that you can do to achieve it. And this presentation today is a perfect example of sort of having some folks help us think about how do you move from theory to practice. So just a couple of housekeeping things. This webinar is being recorded. We don't do questions during the webinar. If you have them during the presentation, go ahead and type them into the questions tab, and we will get back to them at the end of the presentation. And we are definitely leaving time for questions and answers at the end of the presentation. So now to introduce our two speakers, two of my colleagues. I'm very excited for them to be presenting to you today. Paj Nandi, who is the Community Relations and Health Equity Director here at the Department of Health, and then Katie Meehan, who is the Health Equity Consultant. My team had a great training from Katie yesterday, so again, I'm really excited for you all to hear from these two. So I'm gonna let you guys go ahead and take it away.
Wonderful, thank you, Maria, and good morning, everyone. My name is Paj Nandi, and as Maria mentioned, I'm the Director of Community Relations and Health Equity at the Department of Health, and have had the pleasure of being in this role for a little bit over 3 years now. And I am, in addition to providing leadership for our health equity efforts in the agency, I also oversee our community relations and strategic partnerships, including building academic partnerships. So this has been a great passion of mine, and I'm really excited to be able to take this role on at the agency level. Katie?
Good morning, everyone. My name is Katie Meehan, and I'm a health equity consultant for the Department of Health. And I work with Paj closely on a lot of our agency-wide strategic initiatives around equity. So everything from implementing the national standards for culturally and linguistically appropriate services to looking at how we can incorporate an equity lens into our contracting process. So thank you for having us here today.
Perfect. Thank you, Katie. So I want to, before we kind of jump into our presentation today, and just to be respectful of all the participants that have joined us, not knowing that many of you may not know much about the Department of Health, we wanted to share a quick org chart to demonstrate where we, Katie and I, sort of sit in the agency with the Center for Public Affairs. And that's important to note because in the past, the Department of Health has not had sort of a health equity leadership role at the agency level. The work has been happening sort of in pockets across the agency through programmatic efforts. So we've been doing this work through individual programs for a long, long time in the agency, but having sort of a dedicated and systematic approach to health equity is relatively new to the agency, and was really brought together by our Secretary of Health, Dr. John Weisman, who you see here. So again, just a quick overview of our agency. We're a cabinet level agency. We are and have a variety of public health programs, all the way from the core foundational programs like environmental public health, communicable disease, health statistics, et cetera, to community facing programs in our prevention and community health division. We also have a pretty significant in finance, in data vacuum. It's happening with the partners that are sort of hidden behind this org chart. Next slide. So I'm going to actually take 10 seconds to actually ask you a quick question, which is, what is your experience with addressing health inequities? And please feel free to select all that apply to you. This will allow us to gauge sort of your familiarity with this work and also help us kind of guide our conversation today.
Thank you, everyone, for contributing your answers. It looks like we have about 60% of folks joining us with some experience, 35% who have been doing this for a while, and 8% that say this is completely new to me. So thank you for giving us that little bit of information as we move forward.
Wonderful. Thank you, Katie. So, and thank you, everyone. So if you go to the next slide. So we often ask ourselves the question, what does equity work look like? And before we kind of get into the practice of doing this work in a sort of a bureaucratic agency like the Department of Health, I want to really set some context for this work and get into some of that theory, because I think it is important to have that common understanding and groundwork. And I think inherent in this work, we need to acknowledge as public health practitioners and also understand the impact of sort of historical and present trauma, oppression, and racism that impacts all of our communities in various ways. And that's something that we can't take lightly, because it is sort of foundational to the way this country has transformed over its life course as a nation, and how that's impacted many of our systems and policies that we now are part of. So I think when we use these terms, it's important to understand that they have manifested into institutional and structural racism. And for us to really call out these terms is equally important to do this work. And when we talk about structural racism, it's not something that a few people or institutions choose to practice. And this concept is not even about individual bias or prejudice, but really looking at the features of the social, economic, and political systems in which we all exist, and really looking at it from that lens. And I think that work and that understanding is really going to help drive health equity in a totally different way, beyond just some of the theoretical concepts that we have talked about before or in our field. Next slide. So to ensure that we have a common place of understanding and language, Katie and I thought we would share our definition of health equity with all of you. So we say that health equity exists when all people can attain their full health potential and no one is disadvantaged from achieving this potential because of the color of their skin, country of origin, level of education, gender identity, sexual orientation, age, religion, or spiritual beliefs, the job they have, the neighborhood in which they live, socioeconomic status, and whether they have a disability. Now, by no means is this an exhaustive list, but our goal was to be as inclusive as we could be. And we supplemented some of this definition with these graphics that you may have actually seen before. And I will caveat this by saying that sometimes these graphics actually create controversy in and amongst themselves. So please take them with a grain of salt. But it's really to help drive the message home that we've never had a level playing field, and that equity and equality are two different concepts, and they don't mean the same thing. And when we talk about equity, we're really looking at the distribution of power and resources in a different way. We're really looking at who has had access and privilege in the society and has had the inherent power that comes with certain groups and belonging to certain groups, and which communities have continuously and chronically been left out, either intentionally or unintentionally. So the conversation and the mindset really flips from being about equal distribution of resources to equitable distribution embarking on at the Department of Health. Next slide. So this is something that you may be, many of you may be familiar with if you've been in the public healthcare arena around the determinants of health and the social determinants of health. I think we can all agree that health starts in our homes, in our schools, workplaces, neighborhoods, and communities. So really the physical environments and the community environments where we're born, live, work, learn, age, and also play. So while we know that there are many factors that influence health, we often kind of forget that, our genetics, our healthcare access and the delivery and the quality of care, environment, even our individual health behaviors are a smaller subset of the larger pie. The greatest determinant of health is really our socioeconomic factors. And these are factors that oftentimes we may feel are out of scope for the public health arena or the health system arena, but we also know that early learning, education, employment, adequate transportation, social networks, housing, et cetera, all have a significant impact on lifelong health. And while we have embraced health in all policies in some ways through this work, I think it's time that we also shift our focus into health equity in all policies and really looking at how can equity in early learning really transform the early learning landscape and then create health outcomes for our children and those that are going through that developmental stage. How can we have investments in education that really look at students of color in a different lens versus those that have always had the privilege of quality education. So it's really, again, looking at the determinants of health lens from an equity lens as well as we do this work. Next slide.
Great, so I'm going to go ahead and run through a quick example looking at the social determinants of health. So for this one, we're looking at healthy weight. We could really pick any disease or health issue. And imagine that this is a cliff, and basically it is indicating the risk that one of these three people may have towards falling off that cliff into an unhealthy weight. So lots of times we think about, we acknowledge in public health that people have different risks or levels of risk when it comes to a certain health issue or topic. And often the narrative that we attach to that is, okay, the person at lowest risk in terms of acquiring an unhealthy weight, maybe it's because they eat healthy, they exercise often. This person in the middle, maybe we attribute a somewhat balanced diet to them. They have some limited movement in their life. And then this person that we would be really worried about, we would attach the narrative that they don't eat a healthy diet and they have a sedentary lifestyle. And that narrative is basically reinforcing the old narrative when we use an approach to public health, which is that personal health behaviors are really the driver of health outcomes. And as we saw on the slide that Paz just covered, the actual kind of percentage or amount of influence that personal health behaviors have over our health outcomes is a lot less than some of the other factors that we really want to think about when we're applying that equity lens. We would look at what are the social and economic factors that have served as protective factors to give that person the best position and best opportunity to maintain a healthy weight throughout life. So maybe their parents have a college education. When they grew up, there are sidewalks that took them from home to school, so they're able to incorporate daily activity in a very easy and safe way. They grew up in a safe neighborhood. Their school district or community offered extracurricular opportunities like sports so that they stayed healthy. There was easy access to healthy choices at their local supermarket. Their family was able to have space to have a home garden and grow their own healthy foods. And they had a nurturing family environment. This person in the middle here, if we were to really look at the social and economic factors, maybe the narrative that we would repaint would look more like this. They grew up in a single-parent household. They were lucky to grow up in a good school district with extracurricular opportunities. They took the bus to school, so it was safe transportation, but at the same time, not active transportation. They participated in the free and reduced lunch program through school, which did provide them some access to healthy options. But at home, because they grew up in a single-parent household, there was an over-reliance on prepackaged foods, which may not always be healthy. And even though they did get the opportunity to go to college, they were a first-generation college student, which comes with different challenges. And again, if we were to apply that equity lens for this person that we're most worried about and repaint that narrative for them, maybe it would look like this. They grew up in a low-income household. They lived half of their childhood without health insurance. The neighborhood that they lived in wasn't safe, so they weren't out active playing with other kids. The school district that they actually grew up in was underfunded, so there weren't as many opportunities for extracurricular activities. They experienced some different adverse childhood experiences, and just the greater community that that they lived in would be claimed as a food desert. So there weren't access to healthy options at local supermarkets, et cetera. And I use this as an example because the narrative that we use here, that social and economic factors actually drive outcomes, health outcomes, is really important because the narrative that we use shapes the interventions that we prioritize. We often, when we're doing this work, you know, we've come a long way as a public health profession, and we've gotten to a point where we really do recognize the impact of the social determinants of health. However, when it comes to actual prioritization of resources and interventions, we often still find ourselves going directly to what we would attribute to personal, you know, responsibility or individual level interventions. And these are important things: access to health screenings, nutrition education, and exercise programs. But at this point, it's more like providing a fence, you know, to help keep that person from falling off that edge and into the risk of not having a healthy weight or acquiring other, you know, cardiovascular diseases. Those interventions themselves don't actually do anything to change the positioning of the three people that we see and whether or not they are even at risk or if they're at different risk. And so the only way for us to really address that is through policy systems and environmental changes that address those social and economic factors that we saw, both in the kind of examples that I painted here, but again, also in the full comprehensive list of examples that Paj presented on that chart before.
Thank you, Katie. So what does equity work look like in practice? And I think, as many of you may have probably experienced yourself, there is often no roadmap or recipe for this work. There's a lot of expertise and best practices that we have gleaned from, along with integrating the guidance, suggestions, and ideas from our internal partners and community members and leaders to really come up with sort of a roadmap to do this work. And I also want to really emphasize that our public health programs within the Department of Health individually have been addressing health inequities and disparities through their daily work and strategic initiatives for a long time, be it through their contractual agreements, through campaigns, policies, other projects that they're doing. Again, today's conversation is really taking that work to the next level and looking at the agency parameters and supports and sort of that wraparound infrastructure that is needed to really move the entire agency towards advancing health equity. Next slide. We have often experienced that a picture is well worth 1,000 words. And I think this graphic really sums up our current scenario. And this is sort of looking at an unhealthy community, sort of, if you look at the graphic in more detail, leading to poor outcomes. And we recognize that advancing health equity actually occurs on a continuum or spectrum, if you will. So the work of equity, diversity, inclusion that we often hear about is actually on a continuum. And we use the analogy of the stream to demonstrate that what happens upstream has an impact on outcomes downstream. This is probably something you've probably seen before as well. So the root causes of poor health outcomes, those determinants of health, are complex, they're intertwined, and they're linked to the inequities in social, institutional, and the community environmental factors that we've sort of highlighted in this graphic. So racism, ableism, classism, sexism are just, to name a few, are those inequities that are pervasive, that are sort of covert and overt. And unless we pay attention to those inequities that seem like out of our area of sphere of influence, we're probably not going to be able to move the work forward in the most effective way. Similarly, looking at institutional inequities and community and environmental inequities in a very powerful way to really recognize and acknowledge that that is contributing to those poor outcomes that we are all concerned about in the public health and healthcare arena. Next slide. So if you flip the narrative, as Katie was saying, and you look at sort of our vision, and many of us can attach ourselves to this vision and recognize this vision for a healthy community, an equitable community. So the goal at the Department of Health has been, we've been working to integrate principles of health equity into our institutional practices, policies, and procedures. And I want to, again, re-emphasize that we're trying to integrate that lens into the work that we do on a daily basis to maximize our impact on the society and the community environments. And the best way for me to sort of help wrap my brain around this is to really use a 3 buckets approach. So the first bucket, when we look at equity in society, is really focusing on our practices and policies. So when we look at, and we'll kind of get into some of these details as we talk about our work, but if you look at those dot points there, you'll really recognize that when we look at our practices and policies, we're talking about where we have decision-making authority as an agency or as an institution. The next bucket is equitable institutions, or really looking at our people. How do we promote cultural humility of the workforce? How do we make sure that our workforce is representative of the communities that we're trying to serve? How do we ensure that we actually have equitable recruitment, hiring, promotion, and retention practices? A lot of internal work that needs to happen. And then finally, the third bucket is really around partnerships and populations. We all exist to serve others. That's the sort of the preamble of public health. We're here to serve the public. And how do we do that in a very culturally appropriate and linguistically accessible way? How do we make sure that our policies and system changes are actually occurring at that highest level to improve the conditions that determine health? So I think I hope we can share these information with you at a later time as well, but I wanted to at least include these graphics for you to help you understand that our journey is really looking at the entire spectrum and not just looking at those individual parts at one time. Next slide.
So here at the Department of Health, we have 5 overarching strategies that encompass our approach to promoting health equity. So those include infrastructure, data, partnerships, policy, and communication. So this first one, infrastructure, is really kind of an all-encompassing strategy. In a nutshell, it's to build an organizational infrastructure and workforce to promote and support health equity. And I say that it's all-encompassing because there are both internal-facing and external-facing components to this work. So on an internal side, we have a number of diversity and inclusion initiatives, and we also have work around employee training, technical assistance, consultation programs, and efforts like that. And those pieces are around trying to build a workforce that is reflective of the diversity of Washington State at all levels, so not just at the entry level where we've made the most progress, but carrying that reflective diversity through all of the layers of Department of Health and up into our leadership, and also ensuring that our staff here are really operating with a cultural humility lens. And these 2 pieces really address the institutional equity component to those graphics that Paj referenced. On the external facing side, we are looking at what do we need to change internally within our own infrastructure, systems, processes, policies, et cetera, to make our external facing services and programs more equitable. So this includes adding that class lens to everything we do. So looking at, are the services and programs that we provide culturally and linguistically appropriate? We've been implementing this by working with programs to identify opportunities to try and make their programs or initiatives or projects more class compliant. We look at our contracting opportunities. So similar to the internal side, where we're looking at trying to make our recruitment and hiring practices more equitable, take bias out of those systems, we have a similar body of work that needs to happen when it comes to contracting, because that's another opportunity. It's funding, it's employment for the communities and the businesses that compete for those opportunities. And there's a lot of inequities there that we're able to see. And then the third piece, we have a very large focus, at least initially, on language access and also access for individuals with disabilities. And so we are currently undergoing a pretty comprehensive assessment that's looking at what are all of our points of contact that we have with the general public, and therefore what are all the points of contact that we could potentially interact with folks with limited English proficiency or individuals with disabilities. And if they were to interact with us, what would that look like? Would they be able to navigate a service to come get a birth certificate here at the Department of Health, or get information about safety on our website? And so really looking at all of those opportunities and ensuring that they're accessible. So this is one of the examples of efforts that we've started. So back when we launched our health equity work group, we started with an agency-wide survey to really gauge where employees were at. And with this, there were a lot of things that we asked, but one of the questions we asked was what impacts a person's health? And the reason we asked this is we wanted to see where folks were at in understanding the social determinants of health. And as you can see, individual health behaviors still floated to the top. So as I was mentioning during that example I provided, even though as a public health profession, we really moved and we do recognize that social determinants of health have a great influence, we talk about them all the time, when it comes to actually ranking things in terms of influence, we still end up focusing on individual health behaviors. So it's still the default. And from a health equity perspective, we can't get to the point of really integrating a health equity lens into our work until we're able to actually think first with social determinants of health. This is another example of our infrastructure work. So related to the point of contact assessment that I referenced, so looking at all of our interaction points with the public, for us at the State Department of Health, our website is our largest communication tool with the general public. And until recently, most of our information was only available in English. So with that, we were not actually adequately serving Washingtonians because Washingtonians themselves are more linguistically diverse than that. So there has been a large effort here to move to a fully bilingual web. We've made progress with Spanish. We're currently trying to make some progress around the other top 15 languages. There's still a lot of work to do here, but this is the direction that we are hoping to go. And this last example that I'll just reference, if you can look at those, that's 0.32% of all of our contracts or amount spend went out to minority-owned businesses in 2016. So that's a third of 1%. As a state, we aren't doing much better. Some state agencies are a little bit ahead. And on the far right, you see the goals that are set forward for us through Results Washington and heavily influenced by Governor Inslee's Initiative for Supplier Diversity. I will say a caveat to this is it only captures businesses that are eligible for these certifications, and they're specifically called by these names: minority, women, veteran-owned businesses, or small businesses. Those are predetermined certifications. But we do know that even though we do a lot of other, subcontracting or granting out funds to our local health jurisdiction partners and other community-based organizations, that a lot of the same barriers that exist in our contracting processes for these businesses that we see represented in the data also exist for nonprofit organizations, tribal nations, and others who are trying to compete for funding opportunities here at the department.
Thank you, Katie. So our next strategy as we go through sort of our approach to health equity is around data. And I think no one would argue that this is a pretty important part of the work that we do in public health and the healthcare arena. So our goal is pretty lofty: to implement a robust system to collect and analyze data on health outcomes and behavior to assess disparities. Next slide. But the work really is happening at all levels of the agency. Again, we're a pretty diverse agency, and we have a lot of data-specific work happening at the programmatic level, at the division level often, and then also at the agency level. So our focus is really to, again, look at that agency perspective and see what we can do that can actually have a greater impact on a majority of our programs, and also community partners who are interested and invested in this effort. So some of the examples that I have here are creating social determinants of health indicators for the agency. That was actually a request that came out of Healthcare Authority, our sister agency, for their use in their dashboard for their Healthier Washington efforts, which many of you might be familiar with, given that this is a transformation talk. Again, that conversation hasn't ended. I think this work is still going to be ongoing, and we have some other partners that are interested in some of these conversations as well, and for us to really hone in on what those indicators are and how do we actually look at measurement over time. We're also launching a new project. This is still in the planning phase. If some of you haven't heard about it, that's probably because we're still creating this work. we're really interested in having agency standards in how we talk about race, ethnicity, and also how do we talk about other communities that are historically marginalized or have been disproportionately impacted by health disparities. So the purpose of this project is to really gather and use the community feedback directly to improve how the agency talks about and names or identifies different priority populations. I think we've all experienced from conversations with many partners that oftentimes the misrepresentation or the nomenclature that we use in standard surveys, national or state, is not really representative or culturally appropriate to the communities that we're asked that we're asking questions of. We also want to use that information to improve how the agency discusses the disparities and inequities experienced by these different groups. We want to improve how the agency collects and disaggregates data. And we also want to analyze and report on individuals who identify with more than just one group. And that, I think, is becoming a bigger norm than it has been in the past as we understand intersectionality even better. The next two slides, I'm going to talk within the agency and the Health Equity Work Group and our Environmental Public Health Division programs collaborated on this a while ago as part of the CDC's Washington Tracking Network grant. And this tool is called the Information by Location tool that's available, publicly available and internally available for all our programs and partners. And it really lets you explore and compare your community with those you rank, let's say, of 9. That would mean that about 10% of the other communities have a higher proportion of their population living below the poverty level, while 80% have a lower proportion. Similarly, this particular visual here is showing the environmental health disparities map. And that's a relatively recent collaboration that was community-led and community-informed, along with our academic partners and other sister agencies that includes 19 indicators and 4 teams around environmental exposures, environmental effects, some socioeconomic factors, et cetera. And the map really provides new and rigorous insights into where public investments can be prioritized to help mitigate some of those adverse environmental health impacts that we're talking about. So this is just giving you a flavor of the types of tools that our communities have asked for and that we've been able to provide by leveraging federal funds, by leveraging other partnerships, and providing, again, meaningful tools that our partners can use in decision-making and resource allocation. Next slide. The other piece that we've heard constantly from our external partners is how can we better disaggregate data on population surveys? And I think this has been a pretty significant challenge that we've had to overcome. And some of the examples that I'm going to share with you, the one on the slide is really about the State Healthy Youth Survey, which many of you know is a school-based survey that's administered to schools across Washington State in the 6th, 8th, 10th, and 12th grade. And it's really getting at the granularity of information, of rich data, so that we can have more focused interventions, outreach, and engagement. In this example, you can see that we're asking students to identify their race and ethnicity. And I'm using example 4B, Asian or Asian American, which is a pretty huge diaspora, as you can imagine. And I think that doesn't really do a service or doesn't do justice to the cultural nuances of the larger Asian continent and also the sort of the ethnic and racial differences within Asia. So if you look at sort of the second question, it really breaks down into those key communities and nations within that continent and region. We similarly have a focus on asking questions about sexual orientation and gender identity. We've been doing that as part of our behavioral risk factor surveillance systems, which is the adult survey since 2011. But more recently, starting in 2014 and then also in 2016, the Healthy Youth Survey also had a tear-off or sort of an optional piece on sexual orientation for 8th, 10th, and 12th graders. And we're also going to be adding some gender identity questions in 2018, which is really going to help, again, move the conversation from just having national data or anecdotal data to actual real Washington data that's representative of the people that we're trying to serve. And oftentimes, when we don't even collect information on certain communities, they continue to be marginalized, ostracized, and also simply just left invisible in the grand scheme of the work that we're trying to do. Next slide. So our third strategy is around partnerships, and as you can imagine, this is a pretty significant priority for the agency and probably for many of you, because a lot of the work that we do in public health doesn't happen alone, and can't happen alone. It has to happen with partners across the state and in all sectors. So our goal is to really invest in sustained quality internal and external partnerships that are both public and private and multi-sector in nature. Next slide. And I'll just share some examples of partnerships, because obviously we could spend the entire webinar talking about a variety of partnerships within the agency. A key one is the agency's role and representation as part of the Governor's Interagency Council on Health Disparities. If you are not familiar with this council, I highly urge you to visit healthequity.wa.gov to learn more about the Governor's Council. It started in 2006, has 17 members, including the Department of Health, many state agencies, community representatives, and racial ethnic commissions. And it's really advisory in nature, but really helps shape the discourse and the direction of state agencies around health disparities and health equity. And we've been lucky enough to actually align a lot of our work with one of the recommendations that came out of the GUTS Council back in 2016, I believe, to look at best practices to advance equity in state government. So a lot of the work that we're sharing with you today is in alignment with some of the recommendations that came out of the Governor's Interagency Council to really move this work forward. Similarly, there's an interagency equity work group that we participate on. That's really a sort of a learning environment, a platform to share best practices between sister agencies. As I shared earlier, we only know what we know, so it's often really enriching to actually hear from other practitioners like us who are doing this work and to glean from what they're doing. Around multi-sector and diverse partnerships, some of the examples that I've shared here are really at the programmatic level. The Community Health Advisory Committee is something that's been in existence from our Division of Prevention and Community Health that is very multifactorial in nature and really looks at partnerships across the lifespan to address some of those root causes of health around chronic disease and maternal and child health issues. So looking at those policy systems, environmental changes that can really drive the determinants of health. Our HIV Planning Steering Group is another good example of cross-cutting partnerships. It's been the driving force behind our End AIDS Washington initiative that many of you might be familiar with, and it includes even members of the community and people living with HIV/AIDS to have a better representation and voice at the table. Finally, the third dot point under partnerships is around our State Health Improvement Plan, and we have a steering committee that's been recently launched as part of our reaccreditation efforts. And once again, we've invited a pretty diverse group of leaders, community leaders, civic leaders, state and local health leaders to the table to help form that direction and vision for the State Health Improvement Plan, which is really to align existing and promising work that's already happening in the state to drive towards better health outcomes. And as a result of that work and that partnership, our vision is around equity and optimal health for all Washingtonians, which probably would not have been the case had we not heard from some of our diverse partners early on in the planning stages. Along with partnerships, we've been able to produce a lot of standard guides and tools and products for our agency internal partners. And one of them that we're going to talk a little bit about today is the Community Engagement Guide and a related community of practice. So this is something that we've been working as part of our health equity work group efforts, and we've had quite a few members that have been leading this effort, and to really provide some level of standard guidance on how to proactively, meaningfully engage communities while you do your project planning work, while you do policy development, while you do budgeting, and what have you. So if you go to the next slide, I'm going to share a little bit of a snapshot of what our community engagement guide looks like from the inside. So this is a matrix that you may have seen before. It's the community participation continuum, and we heavily borrowed from existing matrices like this from King County Public Health, from CDC, and also from some international sources. But it really gets to the question around how do we and when do we engage communities, and what does appropriate engagement look like, all the way from informing to empowering. And as you can see in the details here, informing is really the state is holding the power and that we're leading the work. And sometimes that may be appropriate and the right role for the state to play, because that is what the authorizing environment is telling us. But oftentimes we actually want to hear and listen and learn from the communities that are going to be impacted most by the work that we're doing. So the goal is always to work towards community-driven engagement, and the guide actually gets into how we can help our programs and our program leaders really understand that and use some of these tactics and tools to better engage communities. If you go to the next slide, I also want to sort of leave you with sort of the definition of what we mean by community. And obviously we know the standard definition of shared beliefs and practices, but sometimes we kind of have to remind ourselves that we interface at the state level with community partners at a variety of levels. And at the state level, sometimes we're also very removed from the actual community that we serve. So we depend on our local health partners, our state associations, our community-based organizations, agencies, and groups to sort of be that conduit to communities. But at the same time, we also partner with community members directly for certain priority projects. And I think that's important to keep in context when we talk about communities and talk about meaningful engagement. Next slide.
Great. So I'm going to do a quick overview of our policy strategy. So we have a strategy all around basically incorporating that health equity lens into all of our policy development processes. And so when I say that, I mean looking at how does health equity need to be considered in the legislation we propose up as an agency, our budget requests. During session, like we are now when we're analyzing bills, are we really looking at the health equity impacts to help inform what our position is as an agency? When bills pass and they come back to us, for rulemaking, how are we adding that equity lens in up front, making sure that the communities that may be most impacted by a certain rule are actively, proactively engaged in the rulemaking process, and that we are removing any of the barriers that they may face to participation. So looking at how do we communicate about rulemaking opportunities and the opportunity for public comment. Are we getting that information out on channels that folks actually access in languages that people understand? When folks actually show up to provide comment, are they coming to a place that is set up to really be accessible for them? So if they need an interpreter, have we proactively provided that? Is it in a facility that is accessible to individuals with disabilities? So really looking at that very holistically. We do work. So I'll give a quick example of some of the work we're doing around incorporating that health equity lens. And so currently for legislative session, we are asking all bills to really be analyzed looking at the potential impacts for certain communities. And so what you'll see here is, down the left-hand side are a lot of the factors and the social and economic factors that we think about. This is also where we see a lot of different disparities and inequities in data. And within any one of those factors, which, by the way, that list of factors is not exhaustive, but within those, there are a number of communities that we really want our programs and staff to think about because we do know that they are disproportionately impacted by policy, often in different ways. So, for example, for age, we know that there are health disparities based on age, and usually the communities that are most impacted in disproportionate ways can be infants and children. Youth are often often neglected, honestly, group within age that we don't always think about, but we do know for certain health issues and health risks, they are at a disproportionate disadvantage. And then also older adults are certain things that just impact our aging communities in different ways. And so that's just one of the many examples we have here. And we've found that over time, having separate resources around, what to think about in terms of that health equity impact that aren't incorporated into existing processes just don't end up being as effective. So for many years, we had a separate health equity resource guide that just kind of sat on the side, and it was a great resource for programs and for staff who had the time and took the pause and moment to go to that resource before working on a policy or analyzing a bill. But what we're really doing now is trying to take those sets of health equity impact questions that we've had historically and integrate those into our internal systems and processes so they become part of the way we think about every aspect of policy development, and then they therefore also have a better opportunity to inform decision making. So this is a very light overview of what our full health equity impact assessment looks like. If folks are interested in seeing what we're currently piloting, they can definitely contact us afterward and we can provide that.
And finally, this is our last strategy, communication. And as you can imagine, this is a pretty important strategy for our work. And if you go to the next slide, I'm going to quickly walk through just some of the few things that we wanted to highlight today. So in addition to doing looking at monthly cultural observances and equity topics that we've been promoting through a lot of our communication channels internally, and having ongoing opportunities for two-way communication, either through consultation, learning opportunities, lunch and learn opportunities. The goal is to really create culture change within the organization and create an environment that actually fosters diversity, inclusion, and equity. And one of the main ways we've been doing that is through something that's pretty innovative for the agency, and we've been doing those for the last few years now. And we call them the Health Equity and Diversity Talks, or are known as HED Talks. And I think, as you can probably tell, it's heavily borrowed from the very popular TED Talks that's out in the universe. So TED Talks have become a platform for us to invite sort of national and state speakers who are doing the equity, diversity, inclusion work in their respective arenas, even addressing determinants of health often, and really inviting them to create dialogue with Department of Health staff and engage them in sort of thought-provoking and provocative conversations about what it means to look at equity from their lens, and how we can impart some of their learnings and lessons learned into the daily work that we do. So once again, this is not an exhaustive list of our communication strategies, but I wanted to highlight some of the key ones that really is building that culture shift and mindset change over time, even though we have a lot of work ahead of us in this domain as well. Next slide. Oh, that's just the example of the HED Talk there.
Great. So we are nearing the end of our presentation, and we want to just leave you with some key questions to help you stay on the equity and justice or social justice track as you are doing your work. So as you're planning new projects, here are some things that we like to always think about up front. So first off, how is the need for this project identified? Who has a voice and who doesn't? How do you address the issues brought forward by historically marginalized groups? How are you ensuring ongoing two-way communication with the communities most affected? What barriers do the communities most impacted face to participating in this project? And lastly, how does the community define success? We often get questions about how do we measure progress and outcomes in our performance. And the first place that we always encourage folks to go is to ask the community that's impacted how they would define success or progress or performance. Those indicators should really be developed by them for them to really be reflective of an equitable approach to a project. And then the second set is if you're not planning something new, but you're trying to improve an existing service or opportunity, really looking at how would someone from a historically marginalized group navigate this service? Who is at an advantage to compete for this opportunity? So again, looking at maybe employment or contracting with that lens. Who currently has access and who doesn't? Do the communities you serve see themselves in your services and opportunities? It's really important for communities, and we hear that over and over again, to see themselves represented, both in terms of diversity and in terms of perspective. What existing systems and processes drive inequitable outcomes? So the inequities and disparities we see in data don't come from nowhere. We obviously have some systems and processes in place that continue to perpetuate those. And so to undo that, we have to really be able to identify what those changes need to be. And then my last one here is the same as my last one for the set above. What would the community define as success in terms of your improvement effort for that service or opportunity? And so that is the end of our presentation here. We have our contact information up. We'd be happy to provide more resources or information on any of our strategies that folks may have. Paj, I don't know if you have anything you want to add before we go to Q&A.
No, not at this time.
Okay, this is Laura Blasky at the Department of Health, and I'll be moderating your questions for our panel. You still have time to type something in, so if you think of something, please go ahead and type it into your chat. If we don't have time for your question today, we'll make sure that Paj and Katie get your questions and can answer them after the webinar. So the first question, I'm just going to go ahead and answer. It's where is the MAP tool available? And the MAP tool is actually at the Washington Tracking Network, and that's on the Department of Health's website. So you can search under Washington Tracking Network and bring up their homepage. And then about halfway down the homepage is something called information by location, and so you can develop your own map. We've had several questions about if the slides are available. Yes, the slides will be posted along with the recorded webinar when that goes up, and that will probably be early next week. Okay, next question. What is the biggest challenge you have faced with this work? And this is for Paj.
Thanks, Laura. I think the challenges has been an opportunity as well for us. I think it's the lack of resources to do this work effectively. As you can imagine, we have a wonderful work group within the agency that's comprised of many leaders and staff from all across the divisions and programs, but they're also volunteering their time to do this work, and because they have a passion and a genuine interest in advancing health equity. But oftentimes that competes with a lot of the work that they have to do as part of their daily work. So it's kind of limiting to have just a few folks doing this work. At the same time, that because we're at the agency level, we're also at a sort of a prime location to help influence some of the strategies and conversations about resources. So we're hopeful that as we advance this work and as people see the impact of this work, the challenge turns into an opportunity to actually resource this work more appropriately.
Great, thank you, Paj. The next question coming in is for Katie. Katie, what has been the most rewarding part of this work?
I'd say the most rewarding part is just seeing progress. And so as anyone, and it sounded like from our first poll, that a lot of folks have some experience doing something around equity. There is no roadmap for this. A lot of it is learning from one another, trying things out, collaborating, and seeing how we go. And so basically a lot of trial and error. And as we actually see some significant changes happen over time, then just in terms of our own infrastructure and how we approach things, I'd say that's the most rewarding piece.
Thank you. And we'll take one more question. Paj, what's your biggest equity win?
My biggest equity win? I would say, I would say the development of the community engagement guide. And I say that because this was a sort of a labor of love that actually Katie led for the agency. And even though we're still in the nascent stages of rolling it out, I think it's going to have significant implications for how we do our work. Because it forms like, it actually forms it's like a web and a weave that we can use to plan and implement and evaluate all the work that we do in the agency. And using that lens for community engagement for everything that we do is really going to be a marked difference from how this agency has operated in the past. So a win even though it's just a tool at this stage, I feel like there's huge opportunity to really operationalize that and use it for all our efforts.
Okay, thank you. And I'd like to just draw everyone's attention to the screen. If you have questions you think of, send them to us at systemstransformation@doh.wa.gov, and we will get them to Katie and Paj. And now I'm going to turn it back over to Maria Corrigan.
All right, thanks, Laura, and thank you so much to Paj and Katie. Great presentation. I just feel lucky to work with you at Department of Health. I don't think we have a February transformation talk teed up yet, but you can see on the screen that there is a website where you can find information about future transformation talks and where today's recording will be posted. So thank you, everybody, for joining us today, and we will talk to you next month. Bye.